Good morning or afternoon, tutor. My name is Rhiannon Eloise Gibbs, and my topic of discussion was, does taste aversion therapy for alcoholism produce behavioural change? Now, I agreed to some extent with this statement, but I think it does depend on the time frame you're looking at for the effect of aversion therapy to remain in effect. So it has been shown to be working up to a year after the therapy, but we haven't really done any future studies, or not that I found, for 5, say 10 years into the future. And also it does sometimes ignore participant variations, so we may look at it may be successful in large groups, but it may not be as effective for some individuals. Now, the experiment that I chose to focus on today was conducted by Canon and Baker, and it was titled Emetic and Electric Shock Alcohol Aversion Therapy Assessment of Conditioning, and it was conducted in 1981. Now, they had previous work in this field, and that's why I chose to summarize this, as I felt that it would give me the most substantial evidence to support my idea or my view of this statement. Now, the aim of this experiment was to find a conditioned response to alcohol from emetic and find evidence of a conditioned response to alcohol from emetic and shock therapy compared to a control group by observation of attitudinal, behavioral, and psychophysiological indicators, thus discovering which was the most effective. Now, the reason behind this study was that previous emetic studies had been proven to be relatively effective, but unfortunately most of them were filled with flaws and sampling issues, so they weren't really valid or reliable. So then there was the shock therapy, and in previous studies that had proven to be less successful. So they just basically wanted to disprove the shock therapy and sort of show that emetic was the most effective. And that follows onto their hypothesis, which was that an emetic would be preferable to shock as the unconditioned stimulus in alcohol therapy. Now, the participants for this study were 20 alcoholics from the Salt Lake Veterans Administration Medical Center Alcohol Dependence Treatment Program. Now, the subjects were randomly assigned to an emetic, shock, or control group, and all were medically screened and diagnosed as alcoholics before the study took place. And also they all underwent normal therapy given at the hospital, as well as their aversion therapy. Now, the method undertook was the participants went through 2 psychophysiological and taste tests before and after their conditioning. Now, the test involved skin conductance and heart rate responses to 6 drinks, 3 of which were alcoholic, 3 of which were not. Now, the 3 non-alcoholic drinks were used as controls. And the subjects then performed a taste test on the beverages, and they rated each using a bipolar semantic differential checklist. After all the participants drank from these 6 drinks, their levels of what they had drunk, their levels of consumption had been recorded. So this was done before and after the aversion therapy, and then it was seen whether they drank more or less after the aversion therapy compared to before the therapy. The taste test was also recorded and shown to blind observers who noted taste aversion behaviors. Now, after these were done, originally in the first part of the experiment, they split into 3 groups: emetic, shock, and control. Now, in the emetic therapy groups, the participants' blood pressures and pulses were recorded before administration of a toxin. The patients were then given their favorite alcohol to swirl around in their mouth, and then 5 minutes after nausea had set in, then they were given a variety of alcohols to actually drink. Now, the patients were then sent to their bed for about 4 hours, and their blood pressure and pulse were continually recorded after this, and also further toxins were admitted to prolong the nausea. For the shock therapy, participants attended 10 shock sessions, and 5 beverages were presented, 5 alcoholic beverages were presented during each session, with their favorite being presented each time. They were told to smell and sip at the alcohol, and then while it was in their mouths, they were given a shock until they spat it out into the adjacent basin. Now, the patients were sometimes found to habituate to the shocks, so therefore the shock amplitude, the shock intensity basically was increased over time, and also the shocks were varied in their intensity as well to promote resistance to extinction of aversion. Now, the control group, they performed the pre and post treatments and testing, and they also underwent the standard inpatient treatment in the hospital. However, they did not complete any sort of aversion therapy, neither shock or emetic. Now, the results showed that the emetic therapy was the only group to record higher skin conductance responses and heart rate responses after aversion. The consumption data showed that aversion only in those who underwent the emetic therapy. Both experimental groups gave more negative alcohol flavor ratings in post-testing. Emetic subjects showed more overtly negative behaviors towards alcohol after the testing. And all of these were specific to alcohol, I should mention. The soft drinks showed no changes in the pre or post testing. Now, whilst the group results were positive, some outstanding individual patient results did appear. For example, one subject showed no observable increased heart rate response after alcohol intake, after the aversion therapy. And some others showed that increased skin conductance responses after aversion were short-lived and did not even last the duration of the experiment. So their skin conductance responses might have been raised during the first post-test, but during the second post-test they would have gone back to normal. It was also some subjects showed marked differences in one area, so say skin conductance, but little difference in other areas, so say their heart rate response, which was an interesting finding. Now the conclusions, basically they concluded from this experiment that the idea that it was strongly supported, the idea that emetic therapy produces alcohol aversion, whereas shock therapy does not. Validity is supported by similar findings in previous experiments in both aversion and shock therapy, and it's believed that emetic therapy is more effective as it is more believable than shock therapy. So you're more likely to get naturally sick from drinking alcohol than what you are to naturally have an electric shock from drinking alcohol. Now, I chose this experiment to summarize because I like that it didn't just support the idea of emetic therapy. I like how it also disproved another conflicting theory, so shock therapy. And it sort of showed which one was successful, which one was not successful. And it was the only one that I found, or that I was summarizing, that had a clear control group of another group of subjects that didn't undergo some sort of aversion therapy. It was good because it was actually simulated in a bar next to the hospital. Oh, not it was a fake bar that they'd set up, and so that would sort of, I guess, stimulate context-dependent cues. So next time they were in a real bar, then they might sort of be more likely to have those feelings of nausea if they were to buy an alcoholic beverage. And it was also good because it was tested afterwards to ensure that the alcohol aversion in participants was non-specific arousal effect. It was not due to non-specific arousal effects. So one test they did was they found that all three groups obtained similar scores in respects to their responses to alcoholic flavors on heart rate and skin conductance measures. Now, this disproved the potential external variable that the participants in the emetic therapy group showed more general anxiety or fear than other subjects. Which would be a external variable. Now, limitations of this study. It was a limitation that not all participants responded as effectively as others. So it means that it didn't really count for individual differences. And yeah, another limitation would be that under varying circumstances, such as higher shock intensities or large number of conditioning sessions, so shock therapy may have been useful in aversion, but they weren't able to do that for basically the time limitations and for safety of the participants. And it wasn't really sure whether the therapy would be effective after the person left the clinic. So they do usually do up to 1 year follow-ups, but I haven't seen any, like I said, for 5 to 10 year follow-ups. So we don't know any long-term sort of effects of this therapy. And at this point in time, the experimenters did not provide they hadn't yet done the follow-up information, so it would actually be interesting to look at those results if I were to come across them, because at the point this was written, it was not up to a year after the experiment, so they hadn't yet done the follow-ups. Now, for future research, I think this has potential for understanding whether there is a predisposition to alcohol, or and if so, it could pave the way for prevention methods to alcoholism. So basically you do a similar experiment where you get people who are believed to be predisposed predisposed to alcoholism, and then you take them and people who you believe are not predisposed to alcoholism. Now you do the similar test with the emetic therapy, and you find out whether there are any different results. So between the two participant groups. So your ones that you don't think are predisposed to alcoholism, then that would be your control group. And if there is a major difference, then it would obviously be seen that there is such a thing as predisposition to alcoholism. And if so, then it might be useful to start this emetic therapy, or finding out whether that is useful in preventing alcoholism, I guess, by emetic therapy. And it may also be effective in future research to provide booster sessions. So before or during the 1 year follow-up, maybe once a month, have them come in for some sort of emetic treatment, just to strengthen the emetic response. That was my summary, and yes, that's all I have to say. Thank you.